that relationship with, a psychologist and psychiatrist, it can be so, so helpful. We get the okay from the patient, can I talk to your psychologist? And, we're going to talk about you. And that open communication can be really helpful.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arno, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area.
All right. Good morning.
Good morning, Dave.
I am super excited. I am going to introduce Dr. Michael Martyna, adult psychiatrist and neuropsychiatrist from Edmonton, Alberta, Canada, in my stomping grounds. He completed his medical school in Calgary, Alberta, and went on to complete residency training in psychiatry at the University of Alberta. He completed his subspecialty training in neuropsychiatry at Stanford University. In addition to seeing patients regularly in hospital and community clinics, Dr. Martyna is actively involved in research and teaching of psychiatric trainees. So again, I'm just really grateful to have Dr. Martyna join us today, agreeing to donate some of his time out of his busy schedule to chat with us and hopefully help kind of demystify and just provide some insight to the listeners and for myself too. I'm really kind of interested to learn more about this area that I'm familiar with, but don't have a ton of professional connection to. So yeah, the medical specialization of psychiatry and his work within the public healthcare system, I'm hoping we can touch on today. But before we do that, full disclosure, I do have to disclose a potential conflict of interest to the listeners here. So here it is. I need to disclose that I am extremely biased. I just really, really, really like Dr. Martyna, or how I refer to him as Mike. He is a wonderful human being. We first met socially about 4 years ago because our beautiful wives started working together. And so we were the plus ones that got together at these social events. And since then, I've been fortunate to get to know him personally, and just, for those, you'll see this very quickly as we're doing the podcast, but he's super down to earth, kind, compassionate, funny, intelligent, and a really generous human being. So he's also become a friend and a soccer teammate. So back when Andrew and I were working on this podcast in secret, recording without telling anyone about it, Dr. Martyna, or Mike, and his wife were actually the first people that I had told that I was working on this. So
I didn't even know that.
Yeah, it's really cool to have him here now join the podcast. We play soccer regularly together, so I see him quite a bit, but we actually don't really shop talk. We haven't really crossed paths professionally. So again, I hope that I can learn a little bit about what you do professionally to add to the picture of who Dr. Michael Martyna is, and that the listeners can learn something here today too. So can you tell us a little bit, Mike, in terms of your professional practice right now?
Yeah, thank you so much for the introduction, and it's great to be here with you guys, Dave and Andrew. Thank you so much for having me on the show. I've known about it for a long time now, longer than most, as it turns out. So I'm excited to finally come on with you guys. As you said in the introduction, in addition to being a soccer player, I'm also a psychiatrist. I do neuropsychiatry as a subspecialty, which is an area of psychiatry that focuses on kind of what it sounds like, the overlap between neurology and psychiatry. So in that context, in my outpatient clinic, which is run by the Public Health Authority here, I see patients who have some other neurologic condition. And then I'm helping them with the kind of psychiatric or mental health side of things, the affect, cognition, behavior. So they might have epilepsy, or they might have had a traumatic brain injury, or a movement disorder like Parkinson's. And then I'll kind of help kind of bridge the gap there. But I also do a lot of general psychiatry. So I work at the University of Alberta Hospital on what's called the consultation liaison team. And in that role, I see patients who are admitted to the hospital. So they're sick for some reason. They might be in the ICU, they might be admitted to surgery, cardiology, medicine. And then they consult our team to come and see them for kind of whatever the issue is that might have come up, which can be really, really wide reaching when we're seeing folks in the hospital here. And so, yeah, I spend a lot of my time seeing patients in all different kind of settings, all different states of wellness and unwellness. And then I also, as a kind of part of working at the university, I'm working with our trainees, which we call residents. So these are the people who have completed medical school, and now they've chosen that they want to be a psychiatrist, and they're going to do 5 years of training in our program to complete that course and kind of become the psychiatrist out the other end. So my day-to-day is split between a lot of time at the hospital, some time down at my neuropsychiatry clinic, and then also another clinic I'll probably talk about a little bit later when we're getting into some of the treatment side of things, where I work at a clinic that does something called transcranial magnetic stimulation, which is a treatment for depression.
Nice. I'm really excited for this episode. Everything that you touched on, including TMS there. We have clients who have been through TMS, who, have been referred out to clinics here that do it out in Toronto. And so I'm really excited to touch on that too. We have listeners from the data that I've gathered, from what I can see. We've got listeners like all across Canada, the United States, in Europe, and so on, just across the world. And I wonder, is psychiatry, like the overall theme of it, working with patients, and I know you did your part of your training at Stanford too, is it pretty much standard across North America, at least in terms of seeing patients, what you do, the field of psychiatry?
Yeah, it is really similar, especially across North America. We use our unified text for diagnosis across North America, the DSM. Though, as you guys, I'm sure know, and some of your listeners might be familiar, we're the only ones that use it, because there's another book, the ICD, which is used everywhere else. And so there are some differences in, kind of the names and how we're kind of grouping things together. But the practice ends up being very similar in North America. There are some, even in the DSM, they talk about like culturally bound syndromes and things that are quite specific to specific areas, but the approach is very similar throughout. We can get into the minutia about, Canada makes guidelines, America makes guidelines, Europe makes really good guidelines. And so there's a little bit different kind of direction about which way to take things in terms of which treatment are you trying first. But that approach, the psychiatric history has been the same format for years, and it's the same format no matter where you're asking the questions.
I guess generally then Mike, just to start off with listeners who may not be familiar with psychiatry, what is psychiatry? So Dave and I are both psychologists, and I think, for the most part, I hope we've done a pretty good job at letting our listeners know what we do in terms of psychology and therapy with children and adults. But can you, I guess, define in a nutshell, what is psychiatry?
Yeah, so probably to put it simply off the top, so psychiatry is a medical subspecialty. So psychiatrists go to medical school, and so when we're looking at kind of mental health through this lens of kind of this biological and medical lens, which is a similar but different approach to our kind of other colleagues that work in mental health, like psychologists. So, we're looking at things like the biology and genetics, other medical illnesses, other medicines, hormones, sleep, how those things might be kind of impacting someone's mind or mood or behavior. So we're usually, part of a team that's helping to treat patients. I don't think there's many psychiatrists that are just kind of working on their own these days. And usually like the other kind of main members of that team would be someone like you guys, the psychologists who are kind of working with the patient, really doing, as you guys have explained in your other podcasts, the psychotherapeutic work and, kind of building people up that way.
So Michael, like from your intro into your practice, I'm actually wondering because like a lot of the times when I think of psychiatry, it's myself, telling someone to go talk to their family doctor and get a referral to psychiatry, right? And so these are generally people kind of seeking out psychiatry. But from what you described, I think a lot of times people just end up in the hospital system and then you get flagged and you show up. And I'm really curious kind of what that's like to introduce yourself to someone who didn't show up to the hospital for psychiatry. And yet here you are.
That's such a good question because that's actually, it's something that I deal with, every day. So when I'm meeting someone, again, I pop into their room, like you said, and I always introduce myself first by saying, because people are meeting so many people in the hospital. So I say, hi, I'm Dr. Martyna. You don't know me yet. I work with the psychiatry team in the hospital. Did you know I was coming by to see you today? And, because then we're kind of getting off on at least I can address, if they have no idea why I'm showing up, we can at least deal with that. So then we can, start to connect and talk. Most of the time, someone told them at least that I was going to be coming by. So we're starting down that way. But that doesn't mean that they want a psychiatrist to be there because there is this, conception, someone like comes in and they've got pain or chronic pain or they need a surgery and they're like, I'm sick. I'm sick. I'm not crazy. Why did they send this person to talk to me? And so, it's kind of, or like families, of maybe a patient who's not able to talk. For some reason, their level of consciousness is low. And then they're asking me like, what's going on? Like, do you guys think he did something? Like, what are you doing here? So it's just, breaking down that barrier first, just be like, no. The team that's taking care of you just wanted me to come by to see if there's anything else that we can do to help. It's distressing being in the hospital. So, we're just here to help kind of support you through that. And we end up that intro can come up with some pretty good content to work with and just kind of, again, getting to know people and getting to know, maybe how much they want me to be helping them when I'm getting to meet them in the hospital.
I think that speaks to the importance of your specialty, though, because to your point, like when someone gets into, let's say, motor vehicle accident, sure, they have broken bones and, perhaps a traumatic brain injury. But usually I found working in a rehab hospital in the past, the last thing that most people think about is mental health. Right. So, yeah, I need to fix my broken bones. I need to go into surgery for my back and so on. But they don't think about mental health until someone like yourself shows up and says, hey, so I've been contacted and how can I help?
Our colleagues we work with in the hospital, really developed a great approach to that. They get us involved or they'll ask questions when they have questions. The trauma patients, it's a perfect example. There's so many different reasons why they need lots of different specialties usually and lots of reasons for them to need our specialty to come by to help. And it can be, part of our role is also explaining to everyone what we do, like to the units, what we can help with. As you guys would be aware of, there are some kind of like do's and don'ts with trauma, especially off the hop. You don't want to do like the forced debriefing. We don't make them talk about it in the first week that they're in the hospital. So just being there for a support for the patient, and part of what we do in our role is a support for the medical teams that we're working with.
That is so interesting. When I think of trauma, I think of past trauma. But sometimes when you're walking into the room, like it's a acute trauma that just occurred, and how you might handle that in that moment, almost like a natural disaster or something like that, where like a team would come in to support people. And so I just think that's super fascinating and not a part of a lot of the work that I end up doing. I have a question that I hear all the time from clients, right? So we're doing psychotherapy, we're working on, let's just say someone with diagnosed PTSD, and we're doing, trauma-focused work. And let's say this person is a first responder or somewhere in that area of work, and they're, interacting with other coworkers. And so they feel like they're making some progress, but they're also hearing from a lot of people around them, like, hey, you should do the medication thing, or you should try the medication thing. But they're just like, what benefit would that do? Or like, I'm not sure how, like, what are the risks? And I know it's a super complicated kind of process, but I think just for anyone considering that, what are the considerations you might let people know, or where they might be able to kind of help themselves make this decision, or even just consult with their family doctor or a psychiatrist?
I mean, it comes up so often, and as you had mentioned, with your clients, I hear this question from my patients almost every time when I'm meeting them for the first time, because that's often, one of the reasons they're there, or one of the reasons their other kind of providers have sent them to talk with me. And the way I like to explain it is that, the medications are one tool that we have in the toolkit. For some people, the psychotherapy, the lifestyle and behavioral changes, social support provides a big part of the care. But there are others when symptoms are severe or persistent, where medications can really help to bring things back into balance. I like to talk about, like, say, for specifically in the example of trauma, I talk about the medications with patients in the sense that, like, they will help stabilize things in PTSD to the point where you're then able to do therapy. Because especially in trauma, like, I believe that, like, where people get better is when they're doing therapy. But the medications can help them get to that point. So it's bringing things back into balance so that they can kind of get back to themselves. So we're making decisions together on what they feel they need. And I can give them the education that I think, when I think, medications can have a role to add that stability. Because there's lots of concern when we talk about the medications. So, like, is it going to change my personality? Are they addictive? Can I ever get off of them?
That's a big concern. That point that you bring up is often a huge concern. So I work with, I would say probably my population is about 80% children, adolescents, and then 20% adults. And I know you don't work with children and adolescents, but oftentimes, whether it's an adult or a parent or even a teenager, and I'm making the recommendation that perhaps we should seek out psychiatry consultation. That's like the first question or statement that's made is it going to change my child, or is it going to change who I am? Is it going to make me really tired and I'm no longer my energetic self, and no longer, my child's not going to be that lively kid anymore. It's going to dull them. Like that's often the first thing I hear.
I mean, that's so important. And the goal of using medications is not to change your personality. It's not to cause you to feel numb so that you're not feeling anything. It's not to kind of, sedate your kids so that they're not then, like their energetic self, like you were saying. All the medications can have side effects. Some are sedating. Some can have this feeling where people will come into me and describe this feeling of, like, being numb when we give that to them. But that's not the goal of the medication. When people come in and they tell me that, that's a sign for me that, okay, that medication wasn't a fit. And so we need to change that, try something else, either another medication or a different treatment route to try to help that person. So the goal is not for those things to happen. What we're trying to do really is just kind of get things, again, I used the word balance before already, because that's kind of how I think of it. They're not going to be like fixing a problem on their own, but they can add balance into a situation and get people more back to feeling like themselves, kind of restored to that sense of wellness that they have had before.
It's nice hearing you talk about this, because there's a metaphor that I use quite a bit when I'm talking to clients about medication. So it's a little bit validating, but I'm open to some feedback or some criticism. I often tell them it's like a life jacket, right? And you still need to swim. And it's just when the waves are crashing over you, right? You might need, like you're saying, that help to be able to do the therapy or to, like, swim. So it's not that it's just you're going to lay there and float. Like, you still need to work at things. So
Yeah.
the medication is not this like magic bullet that just cures everything, but it can definitely allow you to access your own internal resources that you might not have been able to.
Yeah. And I think that's a really nice analogy, actually, a nice way to speak of it. And that is exactly kind of how I try to think about it. There's not many times where the medication is going to do all the work. There are some really specific cases in psychiatry where medications are pretty essential. Think about like severe and persistent like psychotic illnesses, like schizophrenia, maybe like a bipolar illness, where they're like fairly what we could call like quote unquote biologically based. And those medications hold a lot of water because they're doing a lot of work there. But again, in kind of the same way, they're not going to do everything. They're maybe more important for allowing that person to have the autonomy kind of free of other unhealthy kind of like drives to do things that are going to help themselves. So like again, they're not gonna help that person to all on their own by giving them a medication, exercise more or stop smoking. But they're definitely going to make it more likely that they can do it.
So would you say that the medication piece is to try and help someone get back to that functional lifestyle?
Yeah, and that word is so important because function and quality of life is what's important to our patients. And it's really interesting because not much research, really uses like the functional outcomes. It's starting to more now, but lots of our like classic psychiatry research, it uses symptom scores. And when you really get into it with patients, they don't highlight their symptoms as like the biggest concern when they come in. It's their function. It's, are they able to work? Can they spend time with their family and friends? Are they able to take care of their kids? What's their quality of life like day to day? They're not so concerned about like all the specific symptoms that I ask them about when they come. And so, yeah, the medications can really be a tool that helps to improve their function. And as that happens, then you get this like positive snowballing effect where once it's a little bit easier maybe to get some exercise in the day, because it's less daunting to start that, then the exercise starts to become its own medicine. And then they're socializing more. And then that social support, and then so it's really just kind of part of building people up so that they can build this positive inertia.
So when you are prescribing medications and you're talking to the patients about course of treatment, one question that I often get is, well, am I going to have to be on this forever? Like, if I go see the psychiatrist, are they just going to tell me that I'm going to have to be on this for an indefinite amount of time? And I'm assuming that you probably get this question from time to time as well. Like, now that you're prescribing me this, does that mean like I'm going to have to be on this forever? How do you navigate that question?
Yeah, and it's again a really important one for the patients, and part of kind of bringing them into their treatment is that like they should know what I'm thinking when it's about their healthcare, and this is always part of what I'm thinking is not only like which medication should I choose, but how long do I think they're going to be on it? What long-term side effects might we have to manage because of that? The high-level caveat is that it's really different depending on the reason we're using the medication.
Mm.
Again, for like severe and persistent mental illness, like schizophrenia, there is a really strong case that if someone requires a medication, they're probably going to require it for a long time, maybe close to indefinitely. But when we're looking at things, like PTSD or trauma-related symptoms, depression, anxiety, there can be a pretty wide spectrum, but the default wouldn't be to, you're going to have to take this forever. So there are a lot of different things that help our mental health. Medications are one, therapy, all of those other kind of psychosocial and behavioral things. So when people get better or improve, it's not necessarily that the medication is essential to that improvement, but it was probably essential to getting them to that point. And then as I was kind of using that like inertia term, when they've kind of built up the kind of robust kind of wellness and supports and like the general sense around them, the medication might not be as necessary anymore. Yeah, medications usually in psychiatry aren't, I want you to take this starting today And then for the next 90 years, this is going to be, in your hand every morning.
I'm glad you brought that up. I think, especially coming from rural Alberta and even just my own upbringing, right? Almost taking a medication was a sign of weakness, right? So there's already this association that medication should be, only like needed, used as like a last resort kind of thing, right? So I'm just wondering in terms of like patients saying, you know what, maybe I'll try this, but my goal is to get off of this medication as soon as possible. And maybe the second part to this is that where I see this in my office is that people will take themselves off of medication without consulting their physician. And I'm going, whoa, 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 like some of these medications, you just can't stop taking them, even if you feel better or even if you're. So I wonder if you could speak to that part of, what you do.
I'm with those patients, with all the patients, I'm telling them, with the medications, less is more, lower dose, the least amount of time we need to be on it. Like those are my goals as well. But with that said, we have to do it in a safe and reasonable manner. So I always want to let them know about the timelines, right? Because sometimes people are like, well, I took it for a couple of weeks and it wasn't doing anything, so I stopped. And so if I haven't told them that the medication is going to take a month before they start to notice it, and really like 2 months before it's at its maximum or 3 months before it's at its maximum effect, then they're well within their, it's well reasoned to say, I'm not going to take this thing that's not helping me. So, that bringing them in, kind of looping them in on the education about, what I'm expecting the medication to do for them. And then also, this, lots of the times people don't want to be taking medications, which is fair. But I try to tell them all the time, if you want to stop taking it, just call me. Because, again, that's something that we should manage. Now it's because of, potential relapse of the illness. So like another episode of depression, maybe in something like a bipolar disorder, abruptly stopping a mood stabilizer, can cause an illness episode again. And some of the medications truly can have this kind of like a withdrawal syndrome, but it's not due to like an addiction to the medication. It's just, like in diabetes, sometimes your body needs some medication to help kind of bring it back into balance. And in our patients, sometimes they need this medication to help bring things into balance. And so their body's gotten used to the medication being there. So if you abruptly stop it, doesn't feel great. It's not dangerous, and it doesn't mean that their like depression is coming back. Like I missed my medication for one day or for the weekend because I forgot them at home when we were going camping and I felt terrible. So, now I know that was my depression coming back. That's not the case. But they can feel a little bit not great when you're stopping them abruptly, and some more than others. There are specific medications that are kind of big ones for causing some of these unpleasant physical feelings.
Speaking of medications, oftentimes I'll get as patients are starting to talk about, the possibility of treatment through medication. They'll obviously with Dr. Google nowadays, they can go online and just look up all these different medications, what's the most prescribed for anxiety or depression, ADHD, and so on. And then they'll be like, oh, but I've heard about these side effects about this one medication. It's horrible. I'm probably going to be prescribed that. Is this safe to say that there are often more than one medication to treat a condition? And on top of that, being able to play around with dosages as a psychiatrist?
As a rule, there's usually more than one medication available. And we have multiple different classes of medications. And then in each class, there's multiple different medications for the most part. There are a few medications that are kind of in a distinct class of their own, but we have lots of choices when we're making a medication or prescription decision for a patient. And one commonality of the medications is that, all of them may have some side effects, but all of the side effects are usually also manageable and things that we can work through. The medications often have class effects. So it's like this whole family of medications could help with your anxiety, and this cousin medication could help with it as well. And so when I'm making that decision, I'm talking with the patient about why I think a medication might be helpful. And part of what we're doing, because we have these big class effects, so I've got 20 medications that could do the thing we want. It could make your overall level of anxiety lower. When I'm making that decision, I'm looking at all the other things that medication can do as well, both good and bad. So if a medication is also, say, for example, like activating, maybe like makes people feel a little bit more awake, or even, which could be seen as positive or negative, like a little revved up. Sometimes that would be a good thing because some people are saying, like, oh, I'm lethargic, I'm fatigued, I can't. Or some people are maybe like quite somatically or like internally focused. And that revved feeling might be really distressing to them. And if I know that medication can do that, then I won't pick that one. I'd pick another. Or, if it's a medication that can boost appetite. For some people, that's a really welcome thing. Some people are, maybe that's a symptom of the illness that they have, or they have another medical illness that causes them to have nausea and hard time eating. But for a lot of patients that I'm meeting outside of the hospital, when I tell them like, oh yeah, this one might increase your appetite, and actually half the people gain weight when they take this medication, they're like, no, thank you. That's not interesting.
So, Mike, since you're here, I got like probably 150 questions I could ask you. But the one that's just kind of rising to the top as you're speaking, I've heard a bit about like genetic testing and being able to kind of pare down maybe some of the medications that might be more effective or possibly less side effects. And I don't, as my understanding is that it's a bit on the fringes. So right now, but that it is a possibility to help make these decisions about medications. Yeah, I'm curious.
Yeah, so these genetic tests are part of this kind of like goal, this ideal of like precision medicine in psychiatry. So where you could, take a person and their phenotype or like how they present, like what kind of depressive symptoms they have. And so you combine all of that together and then you get, an answer. What these genetic tests allow is maybe a step towards that, but we're not quite there. It lets us know effectively how the medications are metabolized. So through the cytochrome P450 pathway in our liver, medications go through different pathways, and some people can have like a really fast metabolism. So meaning if you take a medication, your body's gonna burn through it really quickly. Or they could have kind of normal, or maybe even in some cases, a slower metabolism. And so those genetic tests, where the evidence base for them is that it can demonstrate that, this person is an ultra rapid metabolizer. So you might need higher doses of a medication, or you might want to avoid all the medications that go through that metabolism pathway at all. There are still some work that needs to be done to get to the point that would say, like, okay, you have, these symptoms of depression. These are the genes we've tested for you, so you should have X medication. We're not quite there, but it is a tool kind of helping towards making that trial and error, which is a regular part of medication prescribing in psychiatry, making that a little bit more smooth.
Anecdotally speaking, Mike, what percent, or maybe not even percent, but from your experience, is this like a typical tool that's getting more and more used, or is it still, is there a population of psychiatrists that are still saying, we're not going to use that yet?
I would say it's not a usual course of practice. Like it's not a standard part of the intro to clinic. It's not something that we use on, like every new patient when we're making a prescribing decision. There are some, private clinics that I know do them a lot. And there are some cases where we would probably be more likely to do it, like when people have persistent symptoms, we've tried multiple medications. When in the research, those usually get termed as treatment resistant. And we kind of have different ways that we would think about approaching those. But it's not a really common thing. I rarely see patients that would come to either clinic or hospital who have had this testing done before.
I guess along the same lines in terms of the genetic testing, So yes, a lot of it is done privately, and so that's where a bit of skepticism comes in. Like if the government isn't paying for it, like should people actually be investing their own money into it? Is it beneficial? And from what I'm hearing is yes, it can be. Um, but also like family history, right? In terms of like whether medication was useful for your parents and like does it make it more likely that it might be useful for you?
Yeah, absolutely. And that's why, like the family history is an important part of our interview process. So like that's why we're asking those questions is one, because, there are, some mental health issues that can, run in families. And the other thing though is that we're almost like trying to sample your genetics by asking a question about, like, was that one helpful for your mom, sister, dad when they had an episode of depression. Because like you were saying, Dave, that can help us, in selecting a medication, efficacy, does it work? That's the most important thing. So aside from all those, like the side effects or the kind of off-target effects that I was talking about, is it going to work? That's the most important thing to the patient sitting in front of me. So yeah, absolutely. Family history is a really helpful guide. And you don't have to pay or get poked for that test.
Yeah, yeah. When I work with families, one of the considerations I will say in terms of like trying to get a referral to a psychiatrist, I will sometimes say, um, we have to think about what are the side effects, sure, but what is also the consequence of, a child who is having a lot of difficulty paying attention in class, right? So, parents will say, well, that's going to decrease their appetite and is it going to mess up their sleep? Is it going to dull their personality? All those different concerns. And, as we're making these considerations, it's like, okay, now the flip side of that though is that they've had a really difficult year in school. And they're getting to an age where they are now learning some things that are very critical for, the next year and the year after that. And they're missing like half a day of school, almost every day, right? So there's the consequence of that. And I'm often trying to provide some of these considerations, not making the decision for them, but also, helping them see the other side of it. Now, in your practice, Mike, what are some of the more common treatments that you will use or diagnostics that you will see in your clinics?
I mean, that kind of clinical scenario that you bring up, it points out something that I think is like so important about psychiatry and maybe not what people think first about it is that because there's a lot of kind of question about, in the ethos about like psychiatry and mental health, like part of what we're doing when we're meeting people is giving them some of this education and, you know, being thoughtful and judicious in prescribing decisions so that, like maybe for that child, we wouldn't maybe, we want to make sure we have the right diagnosis. But usually the decision wouldn't say like, so now I'm telling you, you have to take this medication or XYZ will happen. It's just like you were pointing out, like my understanding of you and your child's situation or you as the patient, your situation is that like this is the benefit that could come from our treatment. This is the potential cost of doing our treatment. And then this is the potential cost of us not doing something together right now. So that, it's meant to be like this collaborative process. There's all of medicines and psychiatry, I would say even more kind of specifically, does have a bit of a history of a very kind of directive approach and, telling people when they should do it and how they should do it. But that's really not the vibe. That's not how we're training psychiatrists anymore. It's to like be this purveyor of mental health literacy, to like bring your patients on board. And then you make this decision together. Like, is this going to be helpful? How could it be helpful? How might it not? And then, like you were saying, what's the downside if we don't do anything right now? And yeah, that was just to kind of like follow that because I thought like that's just like such a big part of what I do every day. It was a good kind of good example of these things that come up because it's never an easy decision. I would imagine even like I don't see children myself, but like for parents, talking to my people I know who are parents, the decision to take a medication or not for their kid. It's a stressful one. And
It's a
so
hard
that's
one.
part of what
Yeah.
seeing a psychiatrist can help with. It can give you the information that you need to make the decision, not make the decision for you.
I guess that's part of the consent process too, then, right? Like you're not explicitly asking about consent per se, but through this collaborative process, they are eventually giving you, I guess, permission to prescribe or not.
Yeah. Yeah, exactly. And so the education component of a consult or an assessment is a big part of what we're doing because like I need to learn a lot about the person I'm seeing, and then they're probably wanting to learn a lot about why they're seeing me.
I actually have this like handout that has all of these questions that I'll give clients and say like, take this to your doctor, take this to the pharmacist, like get the answers to these questions and then make a decision that's best for you. But I think the relationship with the healthcare provider, like the way that you're describing this, that it unfortunately it's not everyone's experience, right? So the
Hmm.
way that you're describing, taking the time to get to know someone, taking the time to explain these things to them, I just feel like that is the ideal situation with a possibly, stressful decision. So I really appreciate that.
Yeah, and it is. It's such an important part of healthcare and medicine these days is that, lots of people are relatively informed, but also lots of people don't have much health literacy, just because, maybe they're an accountant. And so they know a lot about something I don't know much about, but I can do a lot to kind of bring them up to speed on even just like some fundamental understanding of mental health, of, you know, why we why we diagnose things, why we use the medications, so that back and forth, not kind of this one-way street from psychiatrist to you, is really important.
So, Mike, how can psychologists and psychiatrists work together? How can we how can we be a team?
Yeah. And again, such an important part of this because like I had said kind of off the hop, the medications are one tool that we have. And I would say almost all of my patients do have some psychotherapy component to their treatment as well. The patients that I'm seeing outside of the hospital, it is like a fundamental relationship, and it works best when there is kind of the back and forth. I love when I can talk to people's psychologists that they're seeing, because lots of the time they're maybe not in the office that I work in. So when I can collaborate with someone, that's the ideal situation. And so sometimes it's even, when I haven't met a patient yet, right? But their psychologist who knows them well and has seen that the symptoms are pretty persistent and maybe not getting better, I'll get people where they're like, my psychologist actually suggested that maybe it was a time to start a medication. So that can be really helpful. And then on the other side, the first time I'm seeing someone, that is, that's how we learn to do our treatment plans. Our first, safety, ensure safety. And then it's our biopsychosocial model, biopsychosocial spiritual model. So in the bio being, if we're going to be doing medication, some investigations, some neuromodulation like TMS, that would be up there. And then the other parts of the plan to kind of round this out is okay, like what therapy can be helpful here? Because in almost every case, there is a psychotherapy that will be helpful to the person that I'm sitting in front of. And again, just like talking about that, because people have preferences, right? Like some people have the preference to not take any medications. And if I'm seeing them and their symptoms are not so severe that I think they need a medication, like you need to take one, that's my recommendation, you should. I'll let them know that. I say, we can try medication or we could try therapy and we'll see what happens. But some people, it's actually kind of the other way too. I'm like, we could try medication, we could refer you to a psychologist. And they'll be like, tell me more about this medication and, how is it going to help me? And so again, there's education there because we don't want people to think you just take this and you don't have to do anything and you're going to, things will change. but it does go both ways. And as does, again, to kind of get back to the original question, that relationship with, a psychologist and psychiatrist, it can be so, so helpful. We get the okay from the patient, can I talk to your psychologist? And, we're going to talk about you. And, having that open communication can be really helpful. And then in the clinic that I work in as an outpatient, fortunately, I work on the same floor with lots of the mental health therapists that are seeing my patients. So that makes that collaboration process pretty simple. Just walk down the hallway.
Actually, this is maybe a bit of a rant, or my biggest beef with psychiatry is that I just don't have access to it, right? Like it can be months wait lists. Like, so a referral or a referral gets made by the family doctor, but it's, a year and a half down the road. And not that this is nothing that you can solve. I think this is a bigger systemic issue. But maybe I'll just run this scenario by you. Is I'll tell people to go to like Access 24/7, and if they're in the triage process, if they're found to be in need of consulting with psychiatry, that'll happen right away. But the follow-up, I'm curious about the follow-up within the healthcare system. And so if someone does meet with a psychiatrist and it is kind of a one-off and they get a prescription for a medication, what does that kind of look like for follow-up?
It raises such an important issue in our system is, that of access and equitable access. Access to specialists in medicine, psychiatry specifically, is challenging. I imagine that's probably true across jurisdictions, across Canada. I imagine in the States as well, that can be challenging in some areas. But it certainly is true here. And now there are lots of things that we're doing to try to, improve the access. You mentioned Access 24/7, which is a local program in the Edmonton area, where no referrals needed. You can just kind of call, you get an intake, and then you could get into to see a psychiatrist that way. But other referral routes, like you're saying, it is, usually months is how we measure the waits, not days. And again, through Access, that can be different, Access 24/7. But the follow-up in mental health it's really important, especially because the timelines we're working with, like the medications have effects that we're measuring over weeks, not days, right? And so it can be a couple months, it can be 3 months when we want to see about, optimizing dose, things like that. So we have to, probably one of the best solutions we have are these like collaborative care models where we both enhance family physicians' skills and comfort in working with mental health issues. And then we also make psychiatrists available to them so that, one psychiatrist doesn't just kind of take on a load of whatever would be 40 patients or 140 patients. And then that's what they have for their life. That's their, so that you're working with other providers to kind of provide that psychiatric consultation and care and review, and then helping to support others to provide the care as well. Again, mental health concerns are usually longitudinal. They can be episodic in some cases, but in lots of cases they are longitudinal. So that the follow-up is really important, and it is something where we're working on these models to make it better. But I would say, especially if you ask patients, they might say that we still have some work to do there.
Well, if you find something that works in Alberta, bring it over to Ontario. Because sometimes I will tell parents, like, if there is an acute situation, and you can't wait 6 months for a psychiatrist, go to the ER, right? Go to the ER, get triaged, and you'll probably see a psychiatrist who's on call, way faster, and have a follow-up much faster than, 6 months from now. Mike, while we have you here, I think I don't want to miss the opportunity to hop into a conversation on TMS, transcranial magnetic stimulation. You touched on this earlier as we were going through the introductions. Can you tell us what that is?
Yes. So TMS, it is a treatment that is used for treatment-resistant depression. That's its big indication in Canada right now. It also has some other FDA indications, like for nicotine addiction or smoking cessation, some good evidence and research in OCD as well. But the main use is for depression. And so what TMS is, as you said, Andrew, it stands for transcranial magnetic stimulation. Effectively, there's a large magnet that pulses. If you've taken some physics or kind of talked to someone who works in engineering or physics, there's always a small perpendicular electric field to a magnetic field if it's strong enough. And so we use the fact that it makes this little electric field to modulate brain plasticity and activity. So down to the size of about a quarter, we can target a part of the brain and use this pulsing magnet, which pulses a little bit of electricity, to help kind of change the brain in what we think are beneficial ways. And now an important part of this is that it's not causing any permanent change. It's kind of giving the brain the ability to be more fluid or more plastic is the term that we use, to kind of nudge the brain into a state of learning, you could think of. So to use an analogy that I had heard recently from someone, it's the path that you've walked down 100 times. That's kind of the one that's easiest for your brain to just keep going down that path. And the TMS part of its effect is that it's making it a little bit easier. There's been a fresh dirt fill, and now you've got this whole field you can walk through. And so in the TMS machine is basically this magnet and then something that we can use to set the power for the magnet. People come in for treatments that last anywhere from 3 minutes, which is kind of the new treatment, up to kind of the older ones were kind of like 40 to 50 minutes. And it has a really great efficacy for treatment-resistant depression and a pretty favorable side effect profile. So it's well tolerated and pretty effective. So makes it sound like a pretty good treatment in my books.
How often is it being used?
So TMS is increasing in its use. It's really increasing in knowledge about it as well. So in Edmonton, and I would think in most cities now in Canada, we have public clinics for TMS. I work in one of the public clinics downtown, and we also have multiple private clinics. So the availability of the treatment is definitely increasing, though. As we were just talking about, with resource access, I think it's something that could even, like, I have an imagined future where it's even more accessible, and it's more available to people with persistent depressive symptoms, difficult to treat depressive symptoms, those who maybe don't want to take a medication or can't really tolerate medications, even though they could be helpful to them. This treatment is one that if it works, I had mentioned already, doesn't have a lot of side effects, and is relatively innocuous, though it is a pretty big time commitment for people to come in and get the treatment done.
I think you kind of answered this already, but I'm guessing you can't just order one of these machines from Amazon and do it in your home. So you would need a referral from a medical doctor, right?
Yes. Yeah, that's right. And not yet. You can't get the treatment at home yet, but I was talking to an author of this book that is about like the future of neurology and psychiatry. And in that book, they have this chapter where they just imagine, what could it be like if depression were maybe more analogous to diabetes, that it's this, chronic medical concern that you just take a treatment for every day or frequently, and it keeps it at bay. And their thought was the TMS, maybe you have this thing in your house, or maybe it's at Walgreens, and you just go and you kind of, you sit under it once a week, or if it's at home, once a day, and that's your treatment for depression. But no, we're not there. So the machines are fairly substantial. You need a referral and a clinic. They're not without side effect or risk, so definitely need a practitioner oversight still.
So my question to that is, and I'm guessing there may be some listeners who have a similar question, is, okay, if this is so promising, you use the word treatment resistant. So if there's treatment resistant, then we go to this. why not just hop onto TMS right away?
Yeah, and I think that is a really good question. I would be a proponent of having this a treatment that's more available to people as a first line, first choice option. So, how it's phrased right now is that it's first line for treatment resistant depression. So, by definition, you have to have tried other things that don't work. And I think it's because it's, when we compare it to medications, for example, it's a relatively new treatment. It's still been around for decades now. So the evidence base is growing. But again, that would then also open a really significant resource crunch, I think. Though, given, if I had control over the world and a magic wand, I would like to make it very available and also available for someone's kind of first treatment trial of depression rather than, the treatment resistant kind.
Is it typically used in conjunction with medication, or is this like an alternative that is, yeah, I'm curious.
So it can be both, but I would say almost all of the patients that I see at the TMS clinic are also taking medications. Again, because, we're getting referrals for people that have really tricky to treat depression. Most of them have had a couple different medications. They're usually still taking some. Most of them have also done, some individual therapy, some group therapy. And so we get them to keep doing those things because we don't want them to stop with the other things that can help. And then while they're getting TMS, the therapy, for example, can actually be more helpful to them because of this plasticity, because of this like learning state that their brain is in. If they keep going to see their psychologist or doing their group therapy, it can actually be more helpful to them in that time because of the physiologic effects of the treatment. But also if their, depression is getting better, they can engage with therapy more readily, all of those things. So we don't tell people to stop doing any of their treatments, and that includes their medications. So if they're taking them and they're not medications, that might cause a safety issue with TMS or make it less effective, because there are some that do that, then we have them keep taking them.
Can a client just go to, let's say they do have a psychiatrist, can they just go to a psychiatrist and ask about TMS? Like, will most know about TMS and where to access and whether it's the right or wrong treatment?
Yeah, most psychiatrists will know about TMS, and at least the kind of basics of what it's used for. And we do consults at the TMS clinic as well, kind of specifically about that. So for most kind of general psychiatrists, often they'd be able to give you some information about it, as well as a referral to a TMS clinic if they felt it wasn't a reasonable or appropriate treatment.
Yeah, because just listening to you talk about TMS right now, it's like, oh, this seems awesome. Like, we why don't we do it more? And if people are interested, I just tell them to go to a psychiatrist and find out more about it.
And then I do think it's great, and I don't want to come off as someone who's like drinking the Kool-Aid and is like overzealous about it, but I've seen it have a really positive impact on people. I've seen it be, really like a fundamental treatment for people. They kind of keep coming back because it keeps working for them.
And is it something that needs to be indefinite, or is there like a treatment course, like you do this every 6 weeks for a year or something like that?
Yeah. So yeah, really important part of it. And I had kind of alluded to the time commitment. So
Yeah.
an original course of TMS is usually 30 treatments that takes place over 6 weeks. So you come
Oh,
Monday to
wow. Okay.
Friday every day for 6 weeks. So it is a pretty time intensive. It's a human resource intensive treatment.
Yeah.
And that course, that 6 week course, is the treatment. Thereafter, there's a variable length of time that the positive effect will help. So say it helped a person and their depression goes into remission, which is the case for about a third of people who get TMS. The length of time that they stay well is variable, but some people do need to come back for like kind of top up treatments. And then there's different ways that looks like, whether you come back for, a week at a time or some other kind of maintenance or booster protocols, they call them. That varies jurisdiction to jurisdiction of what that would look like. But it is the initial treatment is a discrete kind of 6-week period.
I'm conscious of time, and I think this is a topic for another episode. We can, this is very interesting, and I have a ton of questions, and I'm sure the listeners are also piqued their interest. So maybe in the future, at some point, we'll have you back to talk more about TMS.
Oh, I'd be happy to. You might be able to tell it's one of my favorite things to talk about.
This is such a fascinating topic. To Dave's point, I could go on and keep asking questions about this.
So, Andrew, I know you usually do this, but just kind of reflecting on today's episode, any takeaways that you're walking away with?
I love the collaborative process. It's something almost reinforcing of what I already do, like speaking with psychiatrists and pediatricians. I love the way, Mike, you framed, what was it? The cost, the cost of not going through treatment. Right. Even though in practice, like I have that spiel with clients, I think thinking of it as the cost of not doing a certain treatment is really beneficial. Using those words with certain clients, and then just learning about up and coming treatments like TMS, right? Being able to talk more about this to potential clients who are really struggling, and encouraging them to have a conversation with their physician or psychiatrist about this other kind of treatment that's out there. Dave, yourself?
Well, Mike, I think I want you to talk to my dad, because I think, it's hard to get him to take an Advil when he's in pain. So just the way that you've described, the way you kind of are really like patient-centered and meet patients with whatever questions they have and address the concerns they have and give them the information. It's not this, I'm going to meet with you for 5 minutes and you're going to walk away with a prescription that you have no idea about, right? So I really appreciate the way that you've described it. And I hope, if people are listening, that if that it hasn't been their experience, that they do seek out that kind of care. So I just really like that you've modeled it to the world. That to me is what should be expected when you're trying to make a decision about your healthcare and medication. So thanks.
I was going to say, Mike, I think your patients are very lucky to have you. Even your donating your time today to us really shows, your devotion to the occupation, to the healthcare field, and just being in this field for such a long time. Not everybody has that psychiatrist or physician. So very happy to have met you today, and thank you for talking to us.
Yeah, I was really happy to be here, and it's nice of you to say. It was really nice to be on the show and get a chance to talk with you guys, and hopefully share some helpful information, and maybe make it a little less, decrease the barriers to seeing or finding a psychiatrist for your listeners.
Well, thanks, Mike. I'll probably pass you the ball a little more at soccer now after this. I thought I liked you a lot before, but now it's next level. So yeah, again, if you like this, if you appreciated this episode, this podcast, hit subscribe or like or leave a comment, rate it. It does help it become more accessible to other people. I think it just basically populates it in people's Spotify or wherever you're listening to it from. So it could be a small thing, but it really can help kind of spread the word if you think other people would benefit from listening to this as well. So, all right. Have a good day.
Thank you again,
Take care.
Take good care, guys.